Um, it's my great pleasure to introduce the second speaker for today. It's Karen Trapani, and she will be talking about adherence to optimal care pathways for melanoma. And I think she will have an emphasis on surgical delays in her studies. So Karen completed her training in the Melbourne School of Population and Global Health with a specialization in epidemiology. And I'm very pleased that she's currently with us in our department, working as a project manager and data manager for the new PrimCut project. And previous to her studies in epidemiology, Karen has a career in IT project management, where she's delivered large-scale complex programs of work in public and private sectors, both locally and internationally. I'm very looking forward to what you have to say to us today, Karen.
Thanks, Martin. And excuse me, and thanks very much, Emily, too, for your presentation. That was great to get an insight into those apps, which I wasn't that familiar with. So thanks very much for that. So as Martin mentioned, my research focused on measuring adherence to the optimal care pathway for people with melanoma. And melanoma is a serious public health issue in Australia. On average, 34 Australians are diagnosed with melanoma and 5 Australians die from melanoma every day. Australia has the highest incidence rate of melanoma in the world, and that rate is increasing year on year, having almost doubled since 1982. Melanoma is responsible for more than 23,000 hospitalisations annually in Australia, and more than 15,000 cases of melanoma are diagnosed each year in Australia. And Australia has very high rates of early stage melanoma diagnosis, with 80% of incident cases diagnosed at stage 1 and a further 15% diagnosed at stage 2. And this is usually attributed to Australia's excellent public awareness and education programs for managing skin cancer risk and promoting the need for skin cancer checks. And certainly Emily's given us a great insight into some of the newer approaches to skin monitoring too. And I'm guessing that most local people on the line would be familiar with Australia's Sun Smart program, which was first launched by Cancer Council Australia back in 1981, and it is widely recognised as one of the most successful public health campaigns in Australia's history. And very high rates of early stage detection is good news, as early stage detection is associated with high survival rates. When melanoma is detected early, surgical treatment can be curative, leading to a 99.2% 5-year relative survival when diagnosis is made at stage 1. Relative survival reduces to 73.6% at stage 2 and deteriorates to 26.2% for diagnosis at stage 4. And as my research focused on optimal care pathways, which are also known as OCPs, I'll start by providing a little bit of background on these. So OCPs are national guides that provide the consensus expert view of best practice cancer care. They've been created for 15 different cancer tumour streams, and they were first published over a 2-year period commencing at the end of 2014, and they're updated regularly. OCPs are designed with 2 audiences in mind, patients and GPs. What to expect guides help patients to understand the optimal care that should be provided at each step of their cancer experience, while GP guides impart necessary skills and knowledge to support GPs who manage a broad range of diagnoses and may see a broad range of cancers at low frequency. The melanoma OCP sets the benchmark for melanoma care, aiming to ensure that all melanoma patients receive best practice care, regardless of where they live or where they receive their treatment. And the care covered or described in the OCPs covers the entire cancer trajectory. So it covers best practice recommendations from prevention right through to survivorship and end-of-life care. And one of the areas that the OCP aims to optimise is the timing of care along the patient pathway. Clear and transparent timelines for best practice cancer treatment are an important source of information for newly diagnosed cancer patients and for their carers and their families as well. Amidst the stress and anxiety associated with a cancer diagnosis, clarity on the pathway ahead can provide reassurance to patients. And whilst it's generally accepted that prompt diagnosis and treatment is advisable across cancer tumour streams, it is important to understand the evidence base for these recommendations and to ensure that the timelines communicated to patients are both safe and supported by the health system. Communicating very short timeline recommendations that are not evidence-based can be a source of patient anxiety, particularly if these timelines are not able to be met by the health system. And the melanoma OCP provides recommendations and timelines in a number of different areas. And some of these are the time to diagnosis, the use of multidisciplinary teams or MDTs for treatment planning, the management and communication of treatment plans, timelines for aspects of treatment, and also supportive care. And at the beginning of this research project, we created a framework for measuring adherence to the OCP recommendations, creating a number of measurement metrics based on the recommendations of the OCP, and also investigated potential data sources to enable us to measure those metrics. And in that process, we identified some challenges in sourcing data that would allow us to measure adherence to the OCP. And so we took the decision to focus on a subset of those metrics, being the diagnostic and surgical treatment timelines, as these appeared to be the ones that were most easy to measure. And so there were two intervals from the melanoma OCP that we were interested in measuring. The first was the diagnostic interval, which is the time from the patient's first presentation for medical care to their diagnosis. And the second was the surgical interval, which is the time from that diagnosis to the first surgical treatment, which for melanoma patients is typically a wide local excision, which is sometimes performed in conjunction with a sentinel lymph node biopsy. Unfortunately, our data in the end didn't allow us to measure the diagnostic interval, and so we focused the research on the surgical interval, and that's what I will talk about for the rest of the session today. Now, the published melanoma OCP does not define a recommended time period for the surgical treatment interval. However, providing a recommendation for this timeline is currently under consideration. The melanoma OCP is currently under review, and the draft recommendations include a 28-day surgical treatment interval. So this is a recommendation that patients requiring surgical treatment for melanoma should receive it within 28 days of their melanoma diagnosis. There is variation in recommendations for surgical treatment intervals internationally. Australia, until now, has not published a recommendation for a surgical treatment interval, and this is the same in other countries in the world. The United Kingdom has implemented a 2-week rule, and Europe has a consensus-based guideline which recommends a surgical treatment interval in the range of 28 to 42 days. And so in this research project, we wanted to investigate the surgical treatment interval for melanoma patients who were treated in Victoria and to determine whether they were consistent with the proposed 28-day interval and whether they were associated with patient survival. And this, to our knowledge, is the first study of the melanoma OCP in Australia. So the data for this research project came from Melanoma Research Victoria, a collaborative multi-treatment centre research project with the objective of improving outcomes for melanoma patients. It includes patients who have been treated at one of 5 MRV treatment centres and who have consented to have their medical records included in the database for research purposes. The data is a real-world clinical database, and it includes data about the patient's diagnosis and their treatment. And this includes information on their assessments, their pathology results, and details of surgeries that they have undertaken and the timing of those surgeries. Ethical approval for the MRV research project was already in place, having been authorised by the Peter Mac Human Research Ethics Committee, and our data analysis was undertaken according to the requirements of this ethics approval, which governed data management, storage, and the release of results. The data analysis included patients with cutaneous melanoma, which is melanoma of the skin, and this is consistent with the scope of the melanoma OCP. We focused on patients who had presented to an MRV treatment centre over the last 10 years. Analysis was on the primary site diagnostic biopsy for the first lesion that the patient presented to MRV with. And some patients have multiple lesions. So in that case, we only looked at the data for their first lesion. Patients with lesions at stage 4 at diagnosis were excluded from the analysis based on clinical advice. And only patients who received surgical treatment as the first treatment were included in the analysis. And this was quite an important step, as patients may receive other non-surgical forms of treatment depending on their disease stage, such as radiotherapy or systemic treatment. Preparing the data required a significant investment of time, as multiple records per patient were provided, and these needed to be consolidated in order to build a picture of the overall patient treatment pathway. And this allowed us both to identify the patients who met our inclusion criteria and also to ensure that we calculated their surgical treatment interval accurately. Incomplete data was investigated and referred to the MRV data custodian and excluded from the analysis. The data analysis was undertaken using Stata. We started with a descriptive analysis of the data and then followed that with an analysis of the incidence of melanoma death in the sample and an analysis of the surgical treatment interval. Kaplan-Meier survival curves comparing surgical treatment intervals of less than or equal to 28 days to greater than 28 days were generated, and Cox regression was used to estimate the hazard of melanoma death and the associated hazard ratios. Now, moving to the results. So we started with 3,727 patient records, and after applying our inclusion criteria, this reduced to 2,223 patient records. And after removing erroneous, incomplete, and duplicate data, we had 1,883 patient records for analysis across 4 treatment centres. One of the treatment centres had only 7 patients in it, and so we took the decision to remove these patient records and move forward with our analysis on a cohort of 1,876 patients. So having a look at our cohort and the demographics of the patients that we analysed, 88% of the patients in our cohort were 40 years or older, so only 12% under the age of 40. We had 59% of our cohort were males, and half of the cohort were from the 2 areas of least social disadvantage. And this was based on the CIFA Index of Relative Socioeconomic Disadvantage applied to the patient's residential postcode. 56% of the patients had reported comorbidities, and 58% of the cohort were diagnosed at stage 2 or stage 3. And this is interesting in the context of incidence by stage at diagnosis. As you recall, that 80% of incident cases are diagnosed at stage 1 in Australia. But since the MRV data is from tertiary treatment centres, we might expect that later stage cases will be present and that many stage 1 patients may well be treated in primary care and therefore not make their way into the MRV database. The average surgical treatment interval was 37 days. The median value was 34 days and the interquartile range was 21 to 47 days. And our surgical treatment intervals ranged from 1 to 371 days. Overall, 39% of patients received surgical treatment within 28 days of diagnosis. We also reviewed the surgical treatment interval by stage and found little variation in the median and interquartile range across stages 1, 2, and 3. This histogram shows the distribution of intervals of up to 90 days. There were 48 patients in our cohort, which is less than 3% of the cohort, with intervals over 90 days, and we've excluded those from this graph just for readability. Each bar in the histogram is 1 week, and the blue and the red line indicates the 28-day threshold that we were measuring adherence around. And we can see that 89% of the cohort had received their surgery within 60 days of their diagnosis. And this is interesting in the context of clinical advice, that a 2 to 3 week window was a practical estimation of the amount of time needed for a biopsy result, which is given the date of the diagnosis, to be communicated to a patient via their GP and for a referral to be made and a specialist appointment scheduled. So if we combine this window with the 28-day recommendation, we're starting to approach a 50-day limit. So the clinical opinion was certainly expressed to us during the project that a 60-day window may be more practical in the context of our health system. And whilst overall 39% of patients received their surgical treatment within 28 days, which is shown by the horizontal bar here on this graph, there were some demographic characteristics with levels of adherence that were greater than 39%. And these included patients who were under 40 years of age at diagnosis. In this group, there was a 45% adherence to the 28-day recommendation. Female patients had a 44% adherence. Patients from the residential area of least social disadvantage had a 49% adherence to the 28-day recommendation. Patients with no reported comorbidities had a 43% adherence. We observed very little variation by stage at diagnosis. And there was also variation by treatment centre. So patients who were treated at treatment centre 1 had a 53% adherence with the 28-day recommendation, and at treatment centre 2 had a 60% adherence. And disparities across treatment centres require further analysis. There may be reasons behind this, such as different case mixes, catchment areas and case volumes from treatment centre to treatment centre. Looking at the incidence of melanoma death, there were 169 melanoma deaths in our sample, 41% in the adherence group and 59% in the non-adherent group, and no difference was detected in the incidence rate of melanoma death between those two groups. The Kaplan-Meier survival curve showed very little variation in survival outcomes for the two groups, and they're presented here by stage at diagnosis, and the log rank test p-values provided no evidence against the null hypothesis that the survival functions were equal, so no difference detected there. The Cox regression by stage at diagnosis and adjusted for the covariates of interest found no evidence of variation in the hazard of melanoma death for those with surgical treatment intervals greater than 28 days when compared to less than or equal to 28 days, which allows us to conclude that the hazard of melanoma death is the same in both groups for all stages of diagnosis. In terms of the strengths and limitations of the study, so a strength is that, as far as we're aware, the adherence to the melanoma OCP has not been studied in Australia previously. Our sample included a good number of patients from major Victorian treatment centres, and we had the benefit of clinical input and policy guidance from the MRV Governance Committee and the OCP Expert Working Group. The limitations of the study include the potential for selection bias, as our sample contains only consenting patients, and there may be some bias in the patients who consent to the study. Also, we didn't have access to primary care data. Information about the diagnostic interval and factors distinguishing the patient's care pathway prior to diagnosis would be very interesting to understand. We also excluded patients with very long intervals, which appeared to be erroneous. We had 48 records in total with intervals greater than 1 year or treatment pathways that did not seem sensible, and these are currently being investigated, but they weren't included in our analysis. So these results will be reviewed with the Melanoma OCP Working Group to inform revisions of the Melanoma OCP. Further research could focus on better understanding the causes of delay and on measurement of the diagnostic interval in conjunction with the surgical interval. We're very interested to investigate patients with longer intervals and to better understand the factors that may be related to delays, and this could potentially pave the way for more specific recommendations in the OCP. So in summary, and coming back to the original research question, we found that overall 39% of patients received surgical treatment within 28 days of diagnosis, and that there was variation in adherence across different demographic characteristics. We found no evidence of variation in the hazard of melanoma death between the two groups. And we've also gained an understanding of the range and distribution of surgical treatment intervals in the cohort and the patient attributes associated with variation. We learned that 89% of cohort patients are receiving surgical treatment within 60 days of diagnosis, providing some evidence that surgical treatment intervals of up to 60 days are safe. And in closing, I just wanted to come back to the OCPs. So through this project, I had a very small glimpse into the effort that goes into publishing OCPs. They're an extraordinary resource. It's not easy to distill the complexities of the entire cancer trajectory into a simple, readable, and easily digestible form. And there's no question that these are valuable resources for patients and GPs. In this project, we focused in the end on measuring just one of the recommendations of the melanoma OCP, and this was not without its challenges. So there's more work to be done to measure adherence to all of the recommendations of optimal care pathways, and in doing so, to build knowledge about the real-world impacts of these recommendations and the delivery of best practice care in Australia. And I'd like to acknowledge my supervisors, Anna, Martin and Fanny, for their input and advice during the project, and to give a special thanks to Fanny, who's done a great deal of work in mapping melanoma treatment pathways. Her knowledge and experience of melanoma treatment pathways in general and the MRV database in particular were invaluable, so I thank her very much. Thanks also to David Gyorke and Michelle Wilkinson for their assistance in investigating patient records for patients with very long intervals. And I'd also like to acknowledge the teams working on both the melanoma OCP and the MRV research project, in particular, Sonia Mailer and Karen Winch for their assistance with the MRV database. Thanks everyone for your time and attention, and I would now welcome your questions.
Thank you very much, Karen. That was a fantastic presentation. If you have any questions, just let us know through the Q&A or the chat. I've got them open. And the first question, anonymous question, is, did you investigate any other time intervals aside from the 28-day threshold?
Yes, we did. So we did a bit of exploratory analysis into some other time periods. So we looked at a few things. So we had some clinical recommendations to do some analysis around the 60-day interval, which I already mentioned. And that was really driven by potential health system delays. And we also had requests from clinicians to look at a categorical classification in 30-day intervals, so 0 to 30, 30 to 60, etc. So we undertook that analysis. We also looked at the surgical treatment interval and analysed it as a continuous variable. And then the last thing that we did was took a look via the quartile boundaries. And this was really based on some of the literature and some of the previous studies which had taken that approach. So in all of those cases, we didn't find a different result. So with all of those thresholds, we didn't find any difference in the hazard of melanoma death based on the length of time of the surgical treatment interval. But I guess because the surgical treatment, because 90% of the cohort had their treatment within 60 days, which is it's not a very long period of time, that's perhaps not unexpected.
Great, thank you. Maybe can I ask, so you made a comment about future research on the diagnostic interval, the diagnostic delay. Can you elaborate on what do you think has most impact on outcomes for melanoma patients, the diagnostic delay or the surgical delay within the hospital service?
Yeah, well, I'm obviously don't have a clinical background, so but based on the literature that I have reviewed, there's a really strong interest in understanding that diagnostic delay. And I think, I would really have liked to be able to do that if we had the data. And certainly there were references to that in the literature too, to say that that's a really interesting thing to look at and one that does warrant further investigation. It's not that well studied.
What do we need to do to get the data so that we can map the whole pathway, the diagnostic and the treatment pathway?
So the challenge really appears to be that the diagnosis is quite often happening for melanoma in primary care, which is a little bit unusual. Most cancers, well, many cancers, it is the referral into the secondary or tertiary care where the diagnosis occurs. And so that presents some challenges because data appears to be quite siloed, and getting access to that data is a little bit tricky. And then when you get access, the next challenge appears to be linking that all together. So if we want to get the whole treatment pathway from our health system standpoint, it covers, potentially different groups, and therefore linking that data together certainly doesn't happen at a timeline that's fit in with our schedule anyway. Yeah.
Good. Thanks, Karen. I think there's another question. I think more about the OCPs. At a local health service level, there's ambiguity in the wording and timeframes within many OCPs, which makes it difficult to do meaningful analyses of the timeliness across the stages.
Yeah.
Any comment on that?
Yes. And I agree that is the case. And well, in the melanoma OCP, which is the one that I, got quite familiar with, yes, there was a lot of ambiguity. And I would say that certainly for the melanoma OCP, the refresh that's being undertaken has addressed some of those ambiguities, which is an improvement. And I think that's a really big challenge. I think there's an opportunity to really take that ambiguity out. And I think the other opportunity is to try and standardize some of these measures and metrics across all of the OCPs, which I think would then help perhaps to get the measurement of those metrics integrated into systems and perhaps make that data more accessible I mean, what would be ideal would be to have a real-time dashboard of that, but I feel like that might be a little further into the future.
If there's any more questions, just let us know. Q&A is open and the chat box too, so I'm happy to take any more questions. If not, I've got one more specific question, Karen. I was really triggered by your comment about the stage distribution in the MRV in your data set, with more severe cases presenting in the MRV data set. And one of the explanations I think would be this is a tertiary care hospital taking care of more severe cancer stages. But that also has a question in terms of generalizability. So the surgical delays that you will find in patients in the MRV in highly specialized centers might not represent the surgical delays in all the other centers.
Yeah.
Could you make a comment on that?
Yeah, I think that can definitely be the case. And I think the other point that I didn't really speak to in the presentation was that the MRV database itself, so the MRV database has been collecting data since I think it's 2008. And initially they approached or invited patients to consent regardless of their stage. But midway through, so I think, I can't remember the exact year, but let's say 4 or 5 years in, they proactively changed to recruiting later stage patients. So that could also account for the difference in the numbers. But yes, in terms of the generalizability, it does raise some challenges. But I think it's also another consideration would be whether actually that's okay. And in the OCP recommendations, we need to look perhaps at timeline recommendations by stage rather than just having a general timeline. The only other option, I guess, is to try and find data to analyse that has a more representative sample, more aligned to the general population.
Excellent. Thank you very much. I don't see any more questions from the audience. I'm happy to take